Greetings, everybody. Welcome to our updated talk on thyroiditis. Now, this is a really complicated topic, and I had a video that I made about 10 years ago on this topic, and I was only about a year out of medical school when I made it. So, to say the least, I was a little inexperienced in teaching. So that video is kind of a mess. I do cover a lot of things that was relevant at the time, but there are updated and new approaches to these that is worth updating. And also, I want to kind of point out the most important things because I've looked over some of the step 2 and step 3 study materials, some of the review books, and only a few of these are apparently germane to step 3 and step 2 for that matter. However, it's useful to understand most of the thyroidities because they are all fair game for the exam. So I'm going to point out the most important ones, and then from that point, you can decide whether or not you have the brain space to consider the others, okay? If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I very much appreciate all the contributions I can get to help offset the cost of these videos. And I thank all those of you who have already donated. And if you haven't, definitely feel free to subscribe to my channel. I try to get videos out every weekday, so you'll get alerts when I put new videos up. Okay, so this is just an overview, some important information to know as we go forward and we take a look at each of these individual thyroidities. So thyroiditis is a heterogeneous group of inflammatory thyroid disorders that share some similar features, but there's a lot of caveats. So there is generally with thyroiditis an enlargement or a goiter of the thyroid gland, and typically you can appreciate it on the physical exam, but not always. So you're not always going to get a frank enlarged thyroid. Sometimes it might be enlarged, but you don't really feel it. Sometimes it's not enlarged at all. So if you do have a patient with a goiter, you always have to consider thyroiditis, but you can have a patient with thyroiditis who does not have a goiter. With thyroiditis, because there is some degree of destruction of the thyroid gland, there's going to be some thyroid hormone that gets poured out initially, and that's going to cause a hyperthyroid stage. But eventually, because of that destruction, because of that damage, you will eventually go to a hypothyroid phase, and many of these are self-limited. They self-resolve, so the thyroid heals itself. So what you generally see with these thyroidities is a hyperthyroid phase, then a euthyroid phase as you start to go down in thyroid hormone, then a hypothyroid phase, and then back to a euthyroid state as you have resolved. So as I said, this should always be part of your differential for hypothyroidism, hyperthyroidism, or goiter. If you have significant enlargements of the thyroid gland, or if you have fibrosis, which we're going to see with one of these thyroiditis, it can cause compressive symptoms. And so that can manifest as dyspnea, dysphagia, or a change in voice. Physical exam will often reveal a goiter, but as I said, not always. If you do appreciate nodules, so not a confluently enlarged thyroid, but little nodules on the thyroid, then you absolutely positively have to rule out cancer. So that's very important to know. Thyroiditis tends to be more common in women than in men. There is only one thyroiditis that's equal in the sexes, and it'll make a lot of sense when we get to it why that is. The most accurate test, I'm not going to bring this up with every thyroiditis. The most accurate test for any thyroiditis is a biopsy, an open biopsy. But for most thyroidities, we do not do that. We don't need to do that. We can diagnose it based on labs and based on clinical presentation. Now, you should be familiar with the radioactive iodine uptake test, commonly written as an acronym RAIU. This is very useful in diagnosing thyroiditis, as well as some of the other disorders of the thyroid that are not often classified as thyroiditis, like Graves' disease or Hashimoto's. And this allows you to visualize the activity of the thyroid. So this is normal here on the left, and what you see here on the right is an enhanced uptake of iodine because the thyroid is overactive. And so that is what we see in Graves' disease. Now on labs, of course, with Graves' disease, you're going to see a very high T3 and T4, lots of thyroid hormone. The thyroid is being stimulated by those thyroid-stimulating immune globulins, which if you aren't familiar with that, go back to the hyperthyroid section. And you'll also, of course, have a low TSH, and that's because of negative feedback. Now, with hypothyroidism, you're going to have the opposite. You're going to have very low uptake, and that is typically because the thyroid gland is damaged and it's not taking up iodine, it's not making thyroid hormone. So in this case, you're going to have a low T3 and T4 and a very high TSH because of the lack of negative feedback. Okay. So I went over this in the hyperthyroid section, but there's toxic multinodular goiter and a toxic adenoma where you see nodules on the RAIU scan, and often you're able to appreciate this on physical exam. Now, these are the thyroidities that we're going to talk about. I have them in bold. I will make passive reference to suppurative thyroiditis as we get to the end, but we're going to talk about these 5, okay? So one of them, Hashimoto's, we're just going to briefly talk about because I talk about that in the hypothyroid section. Now, our first one is subacute thyroiditis, often referred to as Decaravane thyroiditis. This is a granulomatous disease, so it's giant cell mediated, and it's likely in response to a virus. So you get a viral infection and then you develop this. So it can happen in anyone, but it tends to happen more in women. The key here is that this is a painful thyroiditis, and there aren't many of them. So they have pain around the neck, the jaw, the upper arms, just mainly in the neck though, and you'll feel the thyroid, and it'll often be enlarged and firm, and very important, tender to palpation. So if you have a patient coming in either with hypothyroid symptoms or hyperthyroid symptoms, or just a painful goiter, you need to think of subacute thyroiditis. So the thyroid symptoms are unreliable early on, but as the disease progresses, they will go into first a hyperthyroid state, then a euthyroid state, then a hypothyroid state. Which one you catch it in depends on when the patient comes in, okay? Now on labs, if you get a SED rate, it'll be elevated because this is inflammatory, and the TSH level will help you determine what phase the disease is in. Okay, so if you have a high TSH, you are in a hypothyroid phase. If you have a low TSH, you're in a hyperthyroid phase. And you can also get T3 and T4 if you want. The differential here is Graves' disease, particularly when you're in the hyperthyroid state. Now, Graves' disease will always be hyperthyroid because you have thyroid-stimulating antibodies or immune globulins. However, if you have decaravanes in the hyperthyroid phase, it can be difficult to tell the two apart. And so that's where it's helpful to get that radioactive iodine uptake scan. Another thing that will help you is that Graves is not painful. They'll have an enlarged thyroid, but it doesn't hurt. The diagnosis here is based on labs. However, the RAIU is going to help you. And what's going to distinguish this from Graves is that the RAIU in decaravanes is going to be low uptake, all right? Whereas with Graves, it's going to be high uptake because we have an overactive thyroid. You can treat this symptomatically because it is self-limited. The treatment of choice for the pain is NSAIDs. Now, why do we go with NSAIDs? They used to say aspirin, but now we've kind of learned that aspirin can displace thyroid hormone, and so it can worsen a hyperthyroid state. So we tend to go with NSAIDs. If that doesn't work for the pain, we can try prednisone. It'll cut down on the inflammation. Now, as usual, if you have hyperthyroid symptoms, if you have a thyrotoxicosis, you can treat the symptoms with propranolol, a beta blocker, if it's just moderate symptoms. If you have more severe symptoms, then you will probably want to go with potassium iodide. Now, if you have hypothyroid symptoms, then you'll go with levothyroxine. That's just replacing the thyroid hormone. And what you'll do is you'll titrate them and monitor their TSH, and you want to get that TSH to normal. You're not monitoring the T4, you're monitoring the TSH. Once the TSH gets into the normal range, they're considered euthyroid. As I said, this is self-limited. The RAIU uptake test is not needed, but it will definitely differentiate subacute thyroiditis from Graves. Okay, Hashimoto's, I just want to briefly cover this because I talk about it in the hypothyroid section, but it is part of Hashimoto's disease. This is also painless. It's enlarged. It is almost always going to present as a goiter, and hypothyroid symptoms will tend to predominate. You can get a brief period of hyperthyroidism, but it's often subclinical, so these patients tend to come in with hypothyroid symptoms. The best initial test here is going to be to get a TSH, and anytime you get a TSH, you can always add on like a free T4 or even just a total T4 and a T3. The diagnosis can be corroborated by getting that anti-TPO or anti-thyroglobulin. However, those antibodies can be present in other autoimmune thyroiditis. And the autoimmune thyroiditis are any of the painless ones, okay? So that helps. Now, with Hashimoto's, this is not self-limited. This will persist forever. So if you go a year, 2 years, 3 years down the road and they've been having hypothyroid symptoms that long, you're almost certainly dealing with Hashimoto's. It's the number one cause of hypothyroidism in iodine-sufficient regions. Levothyroxine is obviously going to be the treatment to replace the thyroid hormone. Remember to follow the TSH. And you should check these patients out for nodules because approximately 8% of nodules in patients with Hashimoto's are malignant. Remember, the next step to do that then is FNA, and you're looking for cancerous cells. Reiu thyroiditis is fairly unique because this is very densely fibrotic and it can invade surrounding structures. So this fibrosis will extend to other cervical structures, including the esophagus, trachea, and musculature. And so we really need to get ahead of this because this can cause some serious damage. This is also going to be a painless goiter, and it typically presents with hypothyroidism. Now, you can get compressive symptoms. This is the one where you really get those compressive symptoms because this is fibrosing. So you get the dyspnea and dysphagia and the tightness and the pressure and hoarseness and cough even. Okay, so when you think of a fibrosing thyroiditis, a really invasive, impinging thyroiditis, think Reiu's thyroiditis. The best, first, and most accurate test in this case is indeed a surgical biopsy. And the reason is because most of these we're going to have to remove the thyroid because it's fibrosing and it's impinging on other structures. So we don't really monkey around with this. So this is the only one where you're definitely going to biopsy this and remove the thyroid. The initial therapy, this is another unique one, and this is new. It's tamoxifen. What the heck? That's something we give for breast cancer. Why does it work in Reiu's thyroiditis? I have no gosh darn clue. But we give tamoxifen. You can give prednisone with it, but tamoxifen is the drug of choice. Now, if you have hypothyroid symptoms, of course, you can treat that with levothyroxine and get them euthyroid. These patients may need surgery if there are compressive symptoms, and often they will go on to need surgery. But the prednisone will really help mitigate some of that inflammation and fibrosis. Acute lymphocytic and postpartum thyroiditis are the exact same process. The only difference is if acute lymphocytic thyroiditis happens within a year after birth, after you give birth, then it's considered postpartum. And if you don't, or if a man gets it, it's acute lymphocytic, but it's the exact same presentation. So this results in a relatively small goiter. It is also painless, and it's also self-limited. There are these distinct phases, as we expect, and so this is really, really common. About 7% of women will develop this after delivery, and some say it's even more. Now, you could have a very mild case where you don't come in, so that may account for the discrepancies in the estimates. This tends to last about a year. So 1 to 2 months after you start with this process, usually after giving birth, you'll have a hyperthyroid phase that lasts 1 to 2 months, and then you'll go euthyroid for a little bit, and then 6 to 8 months of hypothyroidism. Same disease process, as I mentioned. Acute lymphocytic and postpartum are the same disease process. This is, again, a small painless goiter, and the best initial tests are thyroid function tests, which of course include TSH, T4, and T3, and then the RAIU. Treatment is only needed in these disorders if they go into thyrotoxicosis. And so in that case, the best initial therapy is symptomatic, and it would be propranolol. Now, drug-induced thyroiditis is, of course, induced by drugs. And there are certain drugs that do this, and so you want to look at your history, and you want to know some of the more common drugs that do this. The big one is amiodarone and lithium. Obviously, amiodarone is given as an antiarrhythmic. It's used a little less commonly now. Lithium, though, is used all the time. So you really want to associate this with amiodarone and particularly lithium. So with patients who are on lithium, we do check their thyroid function on a regular basis. Interferon alpha is given a little less commonly. It's given in some of the chronic hepatitis. It's also given for various cancers, including malignant melanoma and Kaposi sarcoma, as well as hairy cell leukemia. Then there's IL-2. That's given in a recombinant form in a drug called aldesleukin, and this is given also for malignant melanoma and renal cell carcinoma, and that's given when it's metastasized. Okay, so let's just take a look at what we've got here. We kind of went over all of these. The only one I didn't bring up here is suppurative. That's where you get an actual bacterial or even a fungal infection of the thyroid. This will, of course, be painful. It is suppurative. Commonly, these patients are euthyroid. So typically, these patients will come in with neck pain. And you may or may not feel an enlarged thyroid. The thyroid function tests are going to be normal. And so this is difficult sometimes. So you might get a white count. So you got neck pain and you have an elevated white count, elevated SED rate. You can diagnose suppurative thyroiditis. A lot of times these patients will also have a fever, they'll be sick and stuff. And obviously the treatment here is going to be antibiotics. We give them parenterally, and it's very simple antibiotics, penicillin or ampicillin. And then we didn't really talk about Graves', but I just want to point out one very important thing, the T3 to T4 ratio, which I did talk about in the hyperthyroid section when I talked about Graves'. If the T3 to T4 ratio is more than 20, then you have Graves'. If you have hyperthyroidism and it's less than 15, then you have a thyroiditis, likely, where you're in the hyperthyroid phase. So all of this I went over. You can pause this and print it out if you want. I'll just quickly, though, bring up on the bottom here, any hyperthyroidism, you can treat with propranolol to help with the symptoms. If it's very severe, treat it with potassium iodide and prednisone. And if you're dealing with hypothyroidism, obviously treat it with levothyroxine. So to recap, thyroiditis is inflammation of the thyroid, either due to autoimmune causes, infections, or it can be idiopathic. The basic labs to start out with are the TSH, T3, and T4, and the RAIU scan. The only big exception to this is Riedell's thyroiditis. Some hints. If you have pain, then you're either dealing with decaravan subacute or a suppurative thyroiditis, an infection. And the way you can differentiate this is that if you have a low RAIU, you have some destruction of the thyroid. And so that's going to be a low uptake. Whereas if you have suppurative thyroiditis, the thyroid is actually working pretty well, so you'll have a normal RAIU. If you have a man with a painful thyroid, you're probably dealing with suppurative thyroiditis because that's the only one that's 1-to-1. The rest of them have a female predominance. Dysphagia, dyspnea, and hoarseness, you're dealing with Riedell's thyroiditis. If you have a young woman with a history of autoimmune disorders or a family history of autoimmune disorders, think of Hashimotos, because Hashimotos is so common. It's much more common than the other ones, maybe with the exception of postpartum thyroiditis. Now, the treatment, as I mentioned, hypothyroid symptoms are treated with levothyroxine, follow up on the TSH. Hyperthyroid symptoms are treated with propranolol if they're moderate symptoms. If they're severe symptoms, treat it with potassium iodide and prednisone. Prednisone will be important there because it will cut down on the potential of worsening the hyperthyroidism. Subacute is painful. You'll treat this with actually no aspirin, that's old. So you'll treat this with NSAIDs or prednisone. If that's not enough, you can go on to opiates, but that's typically not needed. Riedel's thyroiditis causes compressive symptoms, so confirm that with a biopsy. That's treated with tamoxifen and steroids. So these are just some things that you'll want to know. If you remember these things, you'll get your questions right. If the patient's hyperthyroid and a total T3 to T4 ratio of more than 20, that suggests Graves'. And if it's less than 15, that suggests a thyroiditis. Now remember, this is a total T3 to T4 ratio, not free. So you got to make sure if you're going to do this ratio that you're ordering the total T3 and the total T4. And then fine needle aspiration is reserved for cold nodules and suspected suppurative thyroiditis. So if you get that RAIU scan and you see something like this where you got a lot of uptake and a lot of uptake, but then there's this little spot where there's no uptake, that's a cold nodule and you're going to want to FNA that.